Welcome to the Family Docs Podcast, brought to you by the California Academy of Family Physicians. I'm your host, Dr. Rob Asibe, CFP's new physician director and core faculty at San Joaquin General FMRP. I'm originally from Los Angeles and currently practicing full spectrum family medicine, including MOUD, here in the Central Valley. As we launch the CFP podcast, we begin with a series called Treating Addiction in Primary Care, focused on medication for opioid use disorders, or however you may have heard it, MOUD, my favorite, or MOUD, or MOUD, or even a new one I recently heard, office-based opioid treatment, or OBOT. Now, throughout this series, you may see or hear pronounced differently, but know that we're talking about is prescribing medication for opioid use disorders and how important it is for your practice and your patients. Deaths due to drug overdose in California nearly doubled from 2015 to 2020. Addiction and substance use disorders can be acknowledged without judgment and treated through appropriate medical, social, and mental health approaches. But why doesn't it happen more? In particular, prescribing has been shown to significantly decrease mortality, but only a fraction of eligible patients get treatment. Evidence-based treatment can save lives. So why aren't more family physicians prescribing MOUD? We begin this series by considering the why. Why are family doctors the ones to prescribe MOUD? In this episode, we will hear from Dr. Raul Ayala and Arianna Campbell, two champions when it comes to helping their colleagues understand that MOUD doesn't pile more on their plates, but instead really enriches their practices, their relationships with their patients, and most importantly, it can save lives. Dr. Ayala serves as the Ambulatory Medical Director at Adventist Health Central Valley Network. He has transformed the healthcare landscape in the Central Valley through the clinical integration of over 50 ambulatory clinics. Arianna Campbell is an emergency department PA with more than 23 years of clinical experience. She is co-founder and also serves as director and co-principal investigator for California Bridge, an organization now known as The Bridge. Now, let's hear some true stories about what it's like when we take the bold step into medical treatment of people with substance use disorder.
I would have rather died than look at one more doctor and have one more doctor see me as somebody unimportant or threaten amputation or threaten, well, this is what you're gonna get. There's nothing you can do that I haven't done to myself over 1,000,000 times and asked myself 1,000,000 times over and berated myself. And so all of that is just my own internal calibration headed back at me. I feel every bit of that. And I think it's so important that we realize what it takes for a person to show up.
Long before I heard the word stigma associated with OUD, I felt the stigma of OUD. We clearly have experienced it for my entire career of 35 years in emergency medicine. But as a parent of a child that suffered from opiate use disorder, I can tell you that I've had people come up to me and ask me where I failed as a parent.
I'm Dr. Raul Ayala, family doctor. I work in the Central Valley. I work with Adventist Health. My work is primarily in a rural health clinic. My focus is our complex care clinic, which is really looking at our top 5% of our sickest patients, which we have a clinic that is more of a whole person where we have behavioral health integration and social work, and a lot of the work that we do is transitions of care. And most recently, we started to work more with substance use disorders and programs throughout our clinics. I'm happy to be here with you, Arianna. I know you and I go back, but if you can just introduce yourself.
Yeah, thank you, Raul. It's great to be here with you. So my name is Arianna Campbell. I am a PA. I actually started out in family practice. Many don't know that. And I've worked in primary care, family practice on and off for years and years. But I also work in the emergency department, and I've worked in the emergency department for more than 20 years. Gosh, I think I'm going on 23 years. And my passion is for treating substance use disorders from every setting. Why? because I've worked in those settings. I work in family practice. I actually am going to start working in a rural health clinic. I work occasionally in an FQHC locally. I work in the emergency department, and I'm just kind of a generalist in all places. And I can tell you it's been really rewarding to take on substance use disorder treatment and to be able to provide that care that so frequently isn't accessed. And part of my passion, I am one of the founders and one of the co-principal investigators of California Bridge. And we're actually now renaming to Bridge because we're doing even national work. And we're really trying to mainstream addiction treatment into all settings, but very namely the emergency department, and utilizing emergency departments as part of that system of care where folks can get access, where the emergency department works with family practice docs, and we're all integrated so that the human beings in our community get care.
Well, that's wonderful. Something that you mentioned that's really important is all settings, right? I think the work that we're doing within our organization, I chair our Opioid Stewardship Committee. As you know, the setting, it's not really outpatient, inpatient, ERs, it's pretty much everywhere. And I think that the work that we're doing really has blossomed into other areas, and looking at our residency programs, our community docs to get involved. But I think bridging those different settings has really been important. And so the last 2-3 years through what we've gone with the pandemic, we've seen more of the mental health focus. And I think a lot of the work that you and I have done together has really been to bridge that piece of behavioral health, substance use disorders. Have you seen an uptick of the substance use disorders, or maybe some areas of focus that you've seen?
What I realized when I started this, and I didn't know this before, is that a lot of my patients have a substance use disorder. We're just not talking about it. So there's this high prevalence. I mean, I know that 1 in 4 of the people I see in the emergency department have a substance use disorder. 1 in 3 in primary care settings, there's been a study, 1 in 3 have a substance use disorder. So it was this strange thing when we weren't addressing it. It was like, my patient wouldn't say anything. I wouldn't say anything because I wasn't really sure how to treat it. And I thought for a long time it was somebody else's job, except for who's doing it. So what I can tell you is only 10% of Americans with substance use disorders receive any type of treatment. 1 in 10. Yet 1 in 3 are in primary care. Like 1 in 3 of your patients right now, as a family doc, have a substance use disorder. And 1 in 20 of them have a diagnosable opioid use disorder. So these are settings very rich where we could provide treatment for people who may not have ever considered it, and provide treatment so it doesn't feel like this out there specialized thing. Just integrating it into our normal practice is better for patients, and it's better for us.
When you mention us conversating with our patients, when we ask the questions, you don't know what you're going to get. We focus on behavioral health. We focus on the holistic part of medicine. But I think that's one of those areas where substance use disorder starts to get a little gray. And what if I ask this question? What if they tell me this? What do I do? Do I have resources? How important is it for medical providers to be comfortable with medications or opioid use disorder treatment? What is your take on that?
For years, I wouldn't ask the question very often, and I kind of didn't know how to ask it because all I had was a list, and that list had been like copied 3 times, and we've all seen these lists, right? They're askew, and they're lists of treatment in the area. And I live and work in a small community, so I get feedback, and the feedback I had always received is, you can't actually go to any of those places. They have like 3-month waits. They have these complex assessments. They say you need $25,000 up front to get in. And so that was awkward. It's awkward to ask somebody a question when you know that the answer that you have is not based in evidence. It's not part of how we usually do things. Like, okay, so you come in and you have diabetes. So I have medication. I know what works. So when I just took substance use disorders and shifted that into what I do with evidence-based medicine, everything made sense. So rather than handing off a list and saying this is somebody else's problem, I educated myself. Oh, wow, there's this medication called buprenorphine. And if I give this medication, it reduces this person's risk of dying from any cause by more than 50%. And wow, most people can start that medication at home if I just prescribe it. And people can get their lives back and stabilize. And then when I looked at that and thought, well, what am I doing for alcohol use disorder? And I looked at the evidence and I said, wow, there's medication out there that will keep people from craving. I just took it into every substance use disorder I was encountering, even tobacco use. And when I just put that into my repertoire of things that I can offer to help people with, it just really did create what you were referring to, that holistic approach. Everything made sense, because this is one of those things that forever I was hitting my head against the wall. And it's almost like this othering. Oh, these people. When I accepted that, wow, these are my patients who I can help, everything made sense.
What would you say would be maybe a 3 or 4 step if I wanted to get started for the first time and I had no idea, how do I even do this? And is it easy?
Well, I mean, that's a really great question. I asked myself this, right? I practiced for 17 years without doing this. So I came from the place where, this isn't what we do. I said all of the things that I've heard. I said them out of my mouth when somebody approached me with, hey, why don't you change your practice? And I know practice changes is hard, right? But there are a few really easy things to do. And what I did was actually, I started looking at the evidence. So there's a lot more resources now than there were in 2017 when I started this. And a passion project has been what we've done at California Bridge to actually build up those resources. I also looked on the CAFP website. You're going to find resources all over the place and just quick videos on how to do this. But I would familiarize myself with a really easy one is treatment for opioid use disorder and buprenorphine. That would be the first thing. The other thing I would do is I would connect with friends. I am a person who likes to surround myself with really smart friends. And so I did that also initially. I can tell you through the California Bridge Project, we have 287 hospitals who are embarking on doing this. Call your local emergency department, call the medical director there, whoever you know in the hospital, ask them who their navigator is. We have substance use navigators all over the state now. You can talk to the medical director and see if they're giving buprenorphine. That's just one avenue. Another avenue you can go down is find out who is a treatment clinic in your community, because we've found treatment clinics in every community. And if they're not right in your community, they should be adjacent to it. Call them and tell them, hey, you're starting to think about giving buprenorphine or giving the right medication at the right time for opioid use disorder. I really want to see what you can do for all substance use disorders. And so you can start by making some friends and by looking at some of the educational offerings out there. What I did personally is I started looking into it. I learned about buprenorphine. That was where I started, and learned more about opioid use disorder, watched some videos on the neurobiology of addiction. So I had a better base understanding of addiction. And then I attended a conference. I went to the California Society of Addiction Medicine conference, and they had a scholars program. It's called the MRF Scholars. And it was this mentored experience, but you don't need to do that every time. You can just find your mentor within your community. And I also saw on the CAFP website that there's a peer support program. So you could just sign up for that and have a peer that you reach out to. I talk to people all the time about buprenorphine. And, I know there used to be these 8-hour course to have an X waiver. All of that, by the way, the X waiver is going away with the MAT Act. Why? Because they're trying to mainstream addiction treatment, because they want us all to give buprenorphine like a Schedule III medication it is, without the barriers. So I would just familiarize yourself with the resources for education. They are aplenty and free. I would find the friends in your community, see who is doing this in your community, and then look for a mentored experience just like they're offering through CAFP. So those are ways I would start. And it doesn't have to be super complex. I didn't have any of that when I started giving buprenorphine. And then I used those activities to enhance what I was doing.
And you know what I found though, Arianna, that has really been like an eye-opener is a lot of the times we don't talk to each other as often as we probably should. Somebody's always doing something pretty cool that you just don't know that they're doing it. And they're a humongous resource. Like for instance, with our work through the Bridge program, we found out that sometimes the ER docs don't know that we have the same docs that are doing this type of substance use disorder treatment in the clinic, maybe across the street. Or how you mentioned, they could probably find a clinic through the Bridge website and the collaborative around the other resources. And I found that the communication piece has always been one of those areas where even not knowing your own organization in a way and highlighting those things, because I think that's another area that I found that has really been a big pivot for us.
That's a really good point. I didn't realize how siloed we were in the emergency department. I didn't realize how siloed I was in family practice. And then once I started reaching out, because this is something where if we're going to support people in our community, having these open lines of communication is really important because we're sharing the same patients. So I always say the emergency department's a fishbowl. Everybody looks in, we look out on everybody. But there was these like sound barriers up, right? We're not communicating. Same thing in family practice. I remember calling a family practice doc and talking to them about treating a patient with buprenorphine. And it was almost surprising, like just having a conversation. And when we break down those barriers with our family docs, our emergency department docs, also with people who are working in our clinics that are treating substance use disorders, just open those lines of communication. This work is actually really fun and the people get really good care. So it's funny, in my community, I know you're in a rural community. I live and work in a rural community. This was started by a family doc. What I'm doing was started by a family doc who recognized that there was nobody in our entire county who was providing this care. And then if somebody was diagnosed with a use disorder, they had to leave their family, their foundation, the things that were actually best at supporting them. So a very courageous family doc started doing this a long time ago. And it wasn't until we connected that I said, oh, we can do that too. We can help you start people on medication. And now we have 4 clinics, all based in that primary care model, who are doing this. A rural health clinic, an FQHC. We have what we call a bridge clinic across the street from our hospital, staffed by a combination of family medicine and addiction medicine trained docs and a nurse practitioner. We have a tribal health clinic that's doing this. And these are all based in that family medicine model.
Do you use medication for your patients with opioid use disorders? You can be an MOUD champion and share your expertise with peers seeking to build medication opioid use disorder treatment into their practice. CAFP is building an MOUD champion network. Visit CAFP's research page for addiction and substance use disorder, familydocs.org/SUD, to sign up today. That's familydocs.org/SUD. Having that centeredness or holistic approach to the care has really done something for our communities. I can tell you that it changes lives. I can just think of a patient right off the top of my head, and I know you probably have many of those where you saw them when they started and they were a transition from the ER. And I usually connect with my patients over something that we have in common. And I remember this fellow, he was a transition, and I think I lost sight of him. He continued his treatment with one of our other colleagues, and I so happened to have a visit with him like a month ago. And he looked different. I mean, everything was different. And I remember him really well because I know he was having some issues with a daughter that he had not talked to because of the substance use disorder. And the first thing he told me was, I'm talking to my daughter. We're having lunch. I know it's not a lot, but for me, it's a lot. And to see like people's lives change over something that we can make an intervention and help people through those things. Can you just tell us about some of the things that you've seen? Because I know there's a lot.
Well, I mean, I'm going to be honest with you. Selfishly, I went to work at the FQHC because I get to see people who we started in treatment a couple of years ago who are stable. I felt like I got to sit there and just hear these great success stories. I have one gentleman who told me that he was told, hey, there's medication to help you. I know you're really struggling, and went to the emergency department, received medication. That was this like tiny chapter. And then I see 2 years later that the same individual said, oh yeah, I have this great job and my wife and I are about to buy a house. They got their kids back from CPS. And this person was without housing when I met them and had just been released from jail. Like I said, selfishly now, if I work in that family medicine space, I get to hear these great stories that a lot of people don't hear. And this person thinks that we're heroes. My shift right before Christmas, I had somebody I had started in treatment and followed through family medicine, somebody who needed a refill, and I saw them, and they just gave me a big hug and whispered, you saved my life. Didn't we all start practicing medicine for those stories? And that is a true story. That is real. And it was literally my last patient before Christmas.
I love that. It's that connectedness. And I know you know that the hugs are different when they say, you changed my life. A lot of the times you don't expect these things to go there. But in a way, I think that's why we're here. And that's why I think your passion comes out and the work and the drive that we have behind this work, because you want more people to see that. I think that's why we want to get more colleagues involved. Let's just say we have a new colleague that's saying, hey, I have this patient. What can we tell our colleague, physician or family doc or medical provider that we can talk to the patient about, hey, when you go to this clinic, this is what you should expect? What can we say that we can relay that message to that patient?
It's very difficult if you're experiencing opioid withdrawal. You get very, very sick, and it's really hard to find treatment. If you are sweating, vomiting, writhing around, and you have to go on the internet and try to figure out where you can go to get treatment, and then you call them and they say, oh, sorry, you should keep using for 3 months. So I think the important part here is if somebody's acutely in withdrawal, we've made it so they can go to emergency departments and get care. And what that would look like if one of your patients called you or a parent or somebody called you and said, hey, they're in opioid withdrawal, and if you can't get them in that day, you could certainly send them to the emergency department. Or if you had time in your schedule and they wanted to come into your clinic, this could be as easy as a prescription and some education for them to start at home. In fact, that's what we do frequently from the emergency department now is prescribe buprenorphine. And you previously had to have an X waiver. That X waiver is being dissolved, and a lot of the regulations, a lot of the barriers around it are going away. So very soon in the near future, any of us could prescribe buprenorphine just like we would any other DEA Schedule III medication. So that being said, if I had a patient who then was saying, well, what if I go to this bridge clinic? Number one, they should be treated with respect, dignity. That's what we're all looking for. Could you imagine trying to go somewhere where somebody looks down on you, uses language that stigmatizes you? You wouldn't want to go there. So you want to make sure that the clinics that are seeing people are treating them with dignity. We try to do a medication first model. We want to stabilize folks and not make them jump through a lot of hoops and get complex assessments. So even if it's a short visit where they get started in treatment, that's great. That's how it should be. And if you can't do that in your office, emergency departments should be able to do that. Then in follow-up to continue buprenorphine, a lot of times there are drug screens required with certain programs, but we don't use drug screens to exclude patients. We don't cut people off if they're using another substance. We simply meet that person where they're at. We use this as a talking point and figure out ways that they can meet their own goals. So it's this very strengths-based and it's very patient-centered because the people who are at the highest risk may be using various substances. You don't want to exclude those folks from treatment or cut them off if they return to use, because we have to acknowledge that return to use is a part of the disease. And just like somebody who has hypertension may experience hypertension again, a person with a substance use disorder may experience craving and use again. And so we want to welcome them into treatment anytime that they access it and consider it a win when they show up and when they're doing the work. So I just talked to some parents of somebody yesterday and they were asking what to expect. And I said, really, the expectation should be that your kid's going to be treated with dignity and with respect.
Yeah, and I think, Arianna, that's so great, because a lot of the times what happens is when we don't have the competency or the experience, we tend to shy people away, or we don't treat those patients here. How holistic could that be that we treat the diabetes and the hypertension and the substance use disorder just like everything else? And I think that makes it a lot easier for us to have conversations with patients. And guess what? If those patients have a substance use disorder, they're more likely to come in for their wellness, right? Because they also need their breast cancer screening. But a lot of the times they don't have that medical home. I just really love the fact that you touch on the dignity behind the awareness that we need to have within our clinic structure, which is really important.
It's funny how, again, broadening your practice so that you're now treating substance use disorders like you would any other medical problem, it actually it makes your job easier, and awkward conversations get less awkward. Let me give you an example. I had a patient who was running out of opioids early. Like I'm sure every person listening to this podcast, of course, you can picture the face and the name. Running out of opioids early, loses them frequently, We suspect that they are potentially taking more than prescribed. Maybe they endorse that and say, yeah, I'm really struggling. I need more than what you're giving me. And you've escalated those doses really quickly. They may endorse that they've had to get some opioids from the street and maybe using extra. And if they don't use, they go into withdrawal. Pretty easy to make a DSM-5 diagnosis of opioid use disorder. And so rather than cutting somebody off, losing a patient, potentially them losing their life. Because if you cut them off of the opioids and don't provide treatment, they're at extremely high risk of dying from an overdose because this is not fixing their opioid use disorder. But what if instead you approached that patient with, hey, I see that you're struggling with this. This may not be the right path for you. I'm concerned what's going on in your life. If you could have a real conversation with that person and offer treatment yourself, rather than saying you got to go to this other clinic now because I've identified you as opioid use disorder. So here's punishment, but rather saying, hey, it looks like you're struggling. What if we tried this other medication that really works, decreases your craving? You won't have to escalate doses. That's really that holistic approach. And you do it from the same place they're getting their blood pressure and their diabetes medications. Because when I meet people and they have this self-realization that they're using more than they should prescribe, I mean, I had somebody the other day who said, I'm not a junkie, I'm not an addict. I don't use that language. People are people first, of course. But rather than making it this othering thing, when you say, no, hey, we can give medication that's just going to be safer for you and where you can stabilize this so you can meet your goals and live your life. How does that sound? That's totally different. That can transform medicine and change lives. And that really is holistic care.
I remember you mentioning something earlier that I wanted to circle back on, and that's the systemic change, the advocacy, whether it's a law or a bill or something that we're all working on somehow. And I can tell you the work that we're doing within our organization, and me being the chair of our opioid stewardship committee for all of our system, a lot of it is how do you build policy? How do you build systems, protocols that will allow you, right? Our work with even the Bridge program to get medication on formulary and people to be okay with doing the treatment and the transitions of care and even having education be out there. So that's one of the first things. But I think the other thing is, where should we be? I know we're integrating into our residency programs. I know we're getting more education out there. The X waiver, I'm happy about. But what are some of the other things that we can get involved with to make real change?
Yeah, we're working on that, right? So the start of this right now, we've been talking to people for 5 years now to say, do the thing. It's really rewarding. It's easy. You can do this. And this MAT Act that was just passed as part of the omnibus legislation, it's called mainstreaming addiction treatment. So take it from there, right? How do you mainstream addiction treatment? In addition to the MAT Act, there's the MATE Act, the MATE Act. And what that did is it's requiring 8 hours of addiction medicine education. And though I'm not a big fan of federal mandates for education, we could use this as an opportunity to get everybody into this shared understanding of how to address addiction from all settings. And that's really important. But from a policy standpoint, I have lots of ideas, Raul, but we had more than 100,000 deaths across the U.S. over the last 2 years, and the death toll has continued to rise. This is going to be more than 1 million people that's anticipated to die from overdoses, opioid overdoses, in the next 6 years, from 2020 to 2029. Really, these are staggering statistics. So this takes big changes. This takes a big push. What have we done with other high-risk medical conditions? You think of sepsis, you think of stroke, trauma. We need to put this in that bucket. So we should have quality expectations. This should be something that we see in through a quality lens. I've done that. I'm doing that. Quality is a spectrum, right? So what you do in quality is you develop these expectations. You continue to move and improve care for people. And we developed a substance use disorder committee, much like we have a stroke committee, a sepsis committee, so that we can improve quality care for people who use drugs. We set baseline expectations. So this is something that we do. We provide care for substance use disorders just like we would for other co-occurring medical problems in the emergency department, in hospitalized patients, in our family medicine clinics, from all settings if we take this on like we would any other medical problem. Now, I do have a lot of people who say, ooh, this is hard. What if there's somebody struggling with a lot of substances? Where's their room? Am I handling that now as a family doc? And I get it. I work in all these settings, so I understand. Well, when somebody's struggling and we have trouble getting them on the right blood pressure medication or with their congestive heart failure or whatever it may be, we have specialists. We do have people that we refer to. But if we own a lot of that from a generalist setting, then we can take a lot of burden and we can increase access to care so much that then patients who are experiencing more challenges will have places that they can go and get immediate treatment as well. So does that make sense? So it really is this shared understanding. When we look at policy, bringing this under expectations and quality, this should be something that people should expect from their primary care doc, from the emergency department. This is something that people should expect access to in their communities, just as they expect if they had a bad cut in their hand that they would get great care, just as they'd expect if they had chest pain, they would get great care, just as they'd expect if they were having trouble controlling their blood pressure or diabetes, that they would get great care.
And I think that goes back to something really important that you mentioned. I think part of the strategies that we have, whether they're health organizations or governmental health departments, it's access, right? The family physician, the primary care doc, the primary care or medical provider has a great opportunity to actually provide that access where normally you would have to go somewhere else or you have to get referred or maybe it takes certain weeks. In concluding this thought around the advocacy, I think we can advocate every patient at a time by getting involved and learning more. As you mentioned, the resources, there's so many resources now that it's almost impossible not to know how. But I think that also the other key thing that I take away from you, and I think that's very important that you bring, is that we should have those conversations with our colleague, phone a friend in a way, have that understanding of how this all works, because I think you're right. I think it is going to take all of us to do this. And it's almost algorithmic of how much growth there is in this area. And patients matter, right? I mean, that's why we're here. And I'm just glad that we've had this conversation, even for this short time, to highlight that there are people suffering, but there's a solution and it's at our grasp and it's here and it's available. And we have people like you who are passionate and advocating. And I think that that's where we need to be and we need to do more of that. Arianna, I'm really happy that you spent time here. Any closing thoughts for our family docs or our medical providers to get involved?
Yeah. Hey, I live in a small community. I work in a small community. People who are dying from opioid use disorder, dying from opioids, dying from fentanyl, these are our kids, sons, daughters, brothers, sisters, parents, right? These are people around us. This is our issue to deal with. So create a movement. One family doc in my county created a movement, and we are building and we are improving care for people who use drugs. I think we have to own the past. We've had overprescribing issues. You've been doing a lot of opioid stewardship, which is very important. But we have to change the future, and our family docs can be the hero here. Just, if nothing else, please treat people well. I say this all the time, Raul, stigma kills people. If somebody is afraid to access healthcare because they will be treated as a lesser human, they are not getting the care they need. So please be kind to people and know that there's help out there, that we're creating a shared understanding of how to do this. And we have resources in California. And I'm so grateful to the California Academy of Family Physicians for doing this really important work. And I'm very grateful to you, Raul, for all of your leadership in this area too. It's saving lives. So thank you.
Thank you, Arianna. And just like we mentioned, our care navigators in those ERs, there's many more heroes out there, but you're one of those. And I've always admired your work since our start and my start working with you in the bridge. And I'm happy that you're continuing to hold that flag because we're learning from more of this. And I think we can definitely change. And really, you're right. It takes one person to change the world, and we're on that track. So thank you for your time.
Thank you.
Thank Thank you for joining us for this first of our 4 podcasts focused on MOUD and equipping family physicians with the tools and resources, and hopefully some inspiration, to learn about serving patients battling addiction. We hope you better understand why primary care really is the place to provide this life-saving treatment for our patients. Dr. Ayala and Arianna Campbell talked about connectedness, about the trust your patients have in you, about seeing patients' lives change right before their very eyes. Now, I definitely could see my patients as I was listening along, and it reaffirmed to me the great work that we are doing as family physicians. We hope you enjoyed their stories, and they set us up for episode 2 with their comments about how damaging stigma can be. We'll dive deeper into stigma, shame, harm reduction, and other important topics, and we hope you will tune in for our next episode of Treating Addiction in Primary Care, titled Break the Stigma, Save a Life. The Family Docs podcast and the Treating Addiction in Primary Care series is brought to you by the California Academy of Family Physicians, the largest chapter of the American Academy of Family Physicians, and the only organization in California solely dedicated to advancing the specialty of family medicine. To find out more about CAFP, visit familydocs.org. If you enjoyed this episode, please share with your colleagues, rate and review us on Apple Podcasts or your favorite podcast program, and be sure to come back for more. To find more resources about MOUD and substance use disorder, check out our webpage at familydocs.org/SUD. The Family Docs podcast was developed, produced, and recorded by the California Academy of Family Physicians. Support for Treating Addiction in Primary Care series is provided by the National Institute on Drug Abuse and the California Department of Healthcare Services. Thanks to Shatterproof for sharing ambassador voices. Until next time, this is your favorite family physician, Dr. Raul Sibe with CAFP.